My name is Porrick Fleming. I'm the postdoctoral research fellow on the Restore program, and I've been heavily involved in all of the research that Steve mentioned, and also some of the research that will be presented later today. But I got off the hook with having to present any, so that's great. But I am looking forward to chairing the first session today, and it's kind of picking up on the point that Steve just mentioned there around permacrisis. So the session is Health System Resilience from COVID to Cost of Living Crisis. And we'll have three presentations. In the second two presentations, we'll hear from our colleagues looking at some of the Restore research. And we will hold off on questions until the end. So I will invite the speakers to sit over here on the benches at the end. So if you have any questions, please do jot them down and you can address them to the speakers at the end. But it is my absolute pleasure to introduce our first keynote for the day, Dr. Ewout van Henneken from the Berlin hub of the European Observatory in Health Systems and Policies at the Berlin University of Technology. We had a nice dinner with Ewout last night, and we were discussing career paths. And Ewout enlightened us that his experience goes beyond having extensive experience of working within and across various European countries. But in his early days, he also spent some time working in the Mexican health system. And he also held a fellowship in the health care policy and practice at Harvard School of Public Health. So needless to say, Ewout is very well placed to discuss some of the comparative international health systems and health policy research that's being conducted during the COVID pandemic. So with that, I'll invite you, Ewout, to speak to us on health systems resilience, lessons from COVID-19 for future shocks.
So I was told that this works immediately when I start clicking. Well, there you go. It does. Amazing. Thank you very much, Steve, and also you, Porrick, for this nice introduction and the invitation to talk a little bit about what the Observatory has been doing in this field and what we have learned. And I'm now also looking at it, what can we learn for future crises? And I'd like to do that by first telling you what we did during COVID and why we did it the way we did it. Also because I think there are important lessons for all of us, especially the research community. Then what we learned, and then some lessons from COVID for future shocks. What we saw was when COVID hit, there was a scramble for knowledge among our constituents. I have to perhaps explain that the European Observatory has several partners, and they're mostly members, countries. Also the Irish government is a partner, but also the Dutch government, many Scandinavian countries, Spain. We even have a payer in the sickness fund in France. And they needed information. And they could find, of course, quite a lot of information already online. There were some databases early on, they were set up, about tracking the cases, hospitalization, deaths, policies, combating the pandemic. And this was all described, but there was a real lack of information on how health systems, in the broader sense, were affected by the pandemic. And this was not about just containing COVID, but also really about how can we maintain essential health services. And during this 2 years that we were doing this, I really also saw that it was moving much more from the initial containment towards much more thinking about how can we keep our health system running. So that's why we set up an online platform, the Health Systems Response Monitor. I hope you've seen it before. Where we collected, organized, and updated country information in more than 50 countries in the European region. I think we went online already in April with more than 50 countries. And of course, the way we did it was we had a template where we asked all the contributors to first, and keep updating the system. And also we updated the questions because of, new questions were arising. And we focused on preventing transmission, ensuring a sufficient physical infrastructure, providing health services effectively, paying for the services, and also governance. And also Trinity, of course, was a partner. I think it's somewhere in the middle there. You can see the logo. Maybe important to mention here is that we designed a template that was kind of low threshold. We wanted those responses from all those countries. We didn't need at that point maybe the most comprehensive comparable information. What we needed was ideas for our constituents, policy options. So that's why, maybe now if you then turn it later into a paper, it's harder, but we needed to come out quickly with some very basic information. So the first step we did is with those country reports that you can just read, we started to distill policy snapshots that were dealing with one, often very simple policy question. For example, who is allowed to vaccinate in a given country? Differences are huge, but it was incredibly helpful for our policymakers to say, okay, hey, in this country, in the pharmacy, you can get a shot. In Germany, it's not allowed that, for example, a nurse administers a shot. It's always the doctor, so it's good, that you can show other countries are doing it differently. Also, other questions about additional money, how much was spent, how are countries getting out of lockdown, all kinds of really quick assessments and comparative information with the main goal of providing options. And what we did with those policy snapshots, we turned those into EuroHealth, which is our quarterly publication. So they're also a little bit easier to do than academic papers because we have a very quick, it's more like a journal, so it's not a tough review process. First about the responses, then we talked about the opportunity to strengthen governance, then we had one that was really about moving towards more European cooperation. It was also done together with the French presidency of the EU at that moment. So really, I think, topical at that point. And then we distilled also this in this book that we did quite early, already in 21, we pushed it out about lessons for building back better, really inspired by the things we saw from our monitor. And then as a final step, and that was, I hope, also a little bit the icing on the cake for all of our collaborators, an opportunity to publish about it, which then also turned to be quite hard. We had to do some additional going back to the database because, as I said, it was not really built that much for strictly comparative, purely comprehensive information. It was about generating options. And I think this is a lesson for us that we, if there's a crisis, what should we be producing? Should we work on papers that come out too late, or should we also think of ways to disseminate our results early? So in that book, we had like 20 strategies. I'm not going to go to talk about all of these. I just wanted to show you that you can see that the topic of governance, leading and governing, gets the most. And I think that is quite telling. I mean, it sounds all, if you look then, so COVID laid bare, as we know, health system vulnerabilities and really failures, and I think you mentioned that too, that we already know exist that we didn't address. And many of them are also in governance. And these are some of those lessons. I will not talk about all of them. I just mentioned a few, like steering the response through effective political leadership, transferring the best available evidence from research and policy, communicating clearly was also already mentioned before, and transparently, very important, with populations and relevant stakeholders, and also what we saw, coordinating across national borders. I mean, this is a little bit depending on what kind of crisis you're facing, but in the pandemic it was important, and all kinds of economic shocks that may be important as well. So this sounds all very obvious, right? I mean, this is all common sense, isn't it? Well, I'm just showing a couple of leaders. Some of them are not around anymore, maybe also because of COVID, potentially. I'm not going to assess, I'll leave it up to you, whether these were effective leaders through the pandemic. But I do see a pattern, maybe you see too, we can discuss about that later. The point I wanted to make is, we saw a huge diversity in political choices and how things were communicated, even between neighboring countries. For example, for me, living in Germany, being from the Netherlands and also following the news, how differently this was done. We need to learn from that and get much better. Of course, you have to respond to a social, economic, political, and cultural values and context that you see in a given country. As an example, I live in Germany. And I was amazed how easily there they say, this is what we're doing, there's a mask policy, public transport, shops, etc. And everybody does it. In the Netherlands, there was continuous debate and unclarity and political tinkering, like, oh, maybe we should, make it a little bit easier and loosen some of these rules. And so you had continuous debate and people get really frustrated about it. Of course, it probably also has to do a little bit with, the differences between Dutch and Germans, and they're there. There's this joke we always say, you tell a Dutch person and a German person to jump. And then the Dutch person says, why? Why should I jump? And the German will say, how high? I wonder where Ireland is on this spectrum, but I think I have an idea, because we were walking through through the traffic here in Dublin together with Steve. So I know where you guys are, more or less, so they're good to know. Of course, take your decision informed by evidence. And we always know that you cannot strictly follow the evidence, and we saw increasingly trade-offs during the pandemic. But make those explicitly and transparently, I mean, yes, we can go out of lockdown, but there will be risks and there will be, other effects. Communicate uncertainty effectively, so to create trust. I think trust is going to be an issue for the next years. It's on the agenda on every international organization. Now we see trust also decreasing in health systems. And of course, and this is going to play a role, I think, going forward in any future shock, fake news. It's going to be a huge challenge, and we have to deal with that. Now also with AI, you can make people say stuff, that they didn't say. So we need to think how to counter that. This is, not just for a viral shock. This can, is an issue, I think, for whatever shock we're facing. Yeah, and in terms about on working across borders, the Monti report was a report that was done by WHO and also with involvement of the Commission, and we helped along a little bit as well, about rethinking policy priorities after COVID. And one of the key findings was that of course, welfare of the EU health system is interconnecting, and perhaps we need to work a little bit more together, but also there are limits to subsidiarity. And sometimes we do need to, transfer some degree of sovereignty to supranational bodies. And of course, we're already, doing that in a way. We have the ECDC and the European Medicines Agency, and now also HERA, the new Emergency Preparedness Response Authority that's been set up, getting new authorities also for, future crises. Then I would like to turn to the topic of financing. Again, and also you talked about it, Steve, ensuring sufficient and stable funds, but also adapting purchasing, procurement, and payment system, and of course with the goal of supporting health coverage. And this was a really interesting example about, in how we worked during the pandemic, because we first did a snapshot. It was actually a partner, I'm not going to name who it was, calling us, we need to adapt our payment systems because some of our providers are going bankrupt. It was not, there was an immediate problem, and they needed options, they needed inspiration, and they wanted to know what are the countries around us doing. So we did a quick review that turned into a policy snapshot, a EuroHealth article, and finally, even a paper. Because, you had to not only pay for COVID, but also really for compensating income loss, depending on the kind of system you have. I mean, some countries are more susceptible to that than others. Yeah, so this was also written down in a paper eventually, one that has been, I think, used quite a lot. Interestingly, the French partner in the sickness fund that we have in our organization, they said that, oh, that's great. They looked at it and they found the information they needed, not in the body of text, but in the annex. Just to show that they wanted some very simple description of something that we didn't find important enough to put in the main body, but they found it in the annex. So, sometimes they're looking for different information than we are. Yeah, another point. We did a lot of work during the financial crisis. We had also a whole report with country case studies coming out back then with very clear, I think, recommendations and also showing how susceptible the health financing systems were, especially to labor market changes, unemployment, etc. And there are solutions for that, but many countries didn't implement these. I'm not going into the detail of those. And even interestingly, when we looked at when we did a paper from HSRM on all the countries with social health insurance systems, we found that the social health insurance systems, the purchasers in the system who are supposed to act as strategic purchasers of care were basically ignored. They didn't implement REACT. They looked at the ministries, and gradually but slowly responsibility shifted towards central government, away from social health insurance funds. Of course, this is different for a more NHS type system, but this should really make us think. I mean, the WHO is promoting strategic purchasing as a policy tool for universal health coverage. But during times of crisis, it apparently doesn't work so great. We actually have a paper on this as well, I'm not putting it in here, where we looked at strategic purchasing during COVID, and we found that it didn't work, didn't take place much. Now going more into the workforce, of course, all the countries went into the pandemic with very different numbers of doctors and nurses. Here you see the numbers of nurses and the numbers of doctors down there. But you have to realize that, okay, maybe it suggests something about how good a country is prepared, but there are so many differences you need to take into account as well. For example, what utilization looks like in a given country. In the Netherlands, for example, compared to Germany. Germany treats 2.5 times the number of people in their hospital proportionally. So even though they have more people, in Germany here compared to the Netherlands, they're probably busier or were busier. So you need to think, take that into account as well. So it was not a guarantee on how well the pandemic was managed. And of course, I can talk about these, some of the strategies to make the workforce more resilient. So much has been written about it. WHO also came out with a big report, scaling up existing capacity of recruiting additional health workers, implementing flexible and effective work approaches, task shifting, reskilling, very important, but of course also supporting, what you also mentioned, Steve. This is all undoubtedly very important, and we need to do all these things. But what I will argue is that we don't enough. That's not enough. We cannot recruit and train our way out of the mess we're in. And I'll show you some data about that on the next slide, I think. What we also saw in the response is that there was a strong focus on primary care, played increasingly a larger role in the response to the pandemic. Really, for example, think of the Lombardia region versus the Veneto region in Italy. Lombardia region, hospital-centric, loads of problems. Veneto region, a good example of an effective primary care system, managed the crisis much better. And we also saw how agile the primary care system was, with new innovations, active outreach, mobile teams, you name it. I'm not saying that hospitals are not important, they are. They also play a role in this, but I think that there's a realization that we need to think of the role of primary care and also in relieving the hospital systems with admissions. So what I'm trying to say is that there is a need for transformation of delivery and new models of care. Systems that are more flexible, can cope with sudden surges in demand, who can scale up and repurpose and redistribute capacity. Perhaps also can provide a dual system of delivery in case if there's another emergency where you have to have 2 tracks and have to implement several patient pathways. Yes, but have we done that? Didn't we already know that we actually wanted to transform our systems and into new models of care? No, we haven't really enough. And again, we cannot train and recruit our way out of this in the short term. So look at this. This is unmet need by healthcare type during the pandemic. It's still quite high. Many countries are struggling with backlog. I understand it's a real problem in Ireland as well. So when we were writing a brief to respond quickly to sort of, okay, what can countries do about this unmet needs and how can they respond to those waiting times? How can they address these backlogs? We come up with 3 recommendations. Of course, increasing supply of workforce and staffing. Of course, you can also do a lot with capacity management and demand management. Again, this example of why are the Germans treating 2.5 times more people than the Dutch in their hospitals. But really, investing in these new models, community-based models of care, also in home care, where you can treat people at, at home or monitor them at home. Rehabilitative capacity, so that hospitals are not, crowded, or that they can then be moved there and there's new space capacity available. Using digital health tools, a lot has been said about that, often sort of as this was the big solution to all our problems, it seemed. And of course, you could see here that almost all countries used more remote GP consultation as an example, and Ireland is doing pretty well on this, this metric here. But of course, there are important caveats here as well. And mostly, I would focus here on, some of the problems that not everybody can equally benefit from these new technologies. I mean, there's also literacy plays a role here. Vulnerable groups probably have more difficulty, using them. So we need to really think how this will not add to, disparities that we already see in inequalities. And we also need to think very honestly about what the implications for quality of the service is. I mean, the evidence is still quite inconclusive about some of these e-health technologies and, what it does, what the outcomes are, and what it does for quality of the health service. So, wrapping up, I hope I'm still on time. What does COVID teach us for future shocks? It's a little bit about what I've been talking about earlier, this idea of good governance being key, financial systems that we really now need to fix, really have a good look at purchasing, payment, procurement, have a good look at the role of purchasers in certain systems, better workforce policy. Of course it is needed, but my main message would be we do need to transform the system and how we deliver. This is the moment, and we are already almost wasting it, I get the idea, because we are already getting flooded with new crises, the perma-crises as you call it. And I'm already seeing that, the attention for these, where everybody was talking about, is maybe already, getting less. And we need to keep this on the agenda, because we need, I think, a transformation to be able to also have a real resilient system in the future. Yeah, well, the point about digital infrastructure, I'll leave that for now. I think it's an important tool, but there are some real important caveats. Maybe final remark, if I may. The observatory, we are focusing now on recovery challenges and building back better, and we are also doing resisting testing, because the proof of the pudding is in the eating, of course. So we have built scenarios, and we're going to pilot them in the next weeks, actually, where teams from us and OECD are going to sit together with national policy makers, present them a scenario, and then what are we doing? And then we can also see how we react, because especially in terms of governance, it's so difficult to measure it. So you need to see, and perhaps a scenario is the way. So there's a textbook or a handbook on resilience testing there. We have some immediate challenges that we're working on. Of course, workforce and mental health. And of course, we have a whole dedicated work program on transformation and implementation of new integrated models of care. So that's all I had to say. I'm looking forward to discussion and hear more from Ireland and some of the challenges and the policies here. Thank you.
Thanks, Pádraig. So I'm Catherine O'Donoghue. I'm part of the Restore team and one of the co-authors of the Presta report. And today I'm just going to give some highlights and some recommendations at the end as well. That'll be a part of the report. So the Presta report, so it's a unique collaboration between the Restore project and the Partnership for Health System Sustainability and Resilience, which is a multicultural, lots of cultures, but multi-country rapid review of health systems, which was led by the London School of Economics and the World Economic Forum. I will have a whole session on that with George later on today. So if you look at the report, there were 7 domains and also case study, which we did on traveller health. So the domains are governance, finance, human resources, service delivery, medicines and technology, population health, and environmental sustainability. But today I'm just going to present and focus on the first 5 domains. So to begin with governance, so looking at the COVID-19 responses in Ireland, so there was good communication. So the politicians and members of NPHET, which was the National Public Health Emergency Team set up to deal with COVID, appeared regularly on national media and social media. There was daily press briefings with the Chief Medical Officer and other people from NPHET. The HSE also held weekly press briefings, and often some of the experts from NPHET often would hold press conferences throughout the pandemic and give the most up-to-date information on COVID and the things that they were working on. Another good thing that happened in Ireland early on is that between March and May in 2020, Ireland was one of the best in Europe at reducing population mobility. So we brought in lockdowns and there was good adherence to the lockdowns. Another good part in Ireland, linked with good communication, was there was high levels of public trust in science and in NPHET. And then moving on to other parts of some highlights from governance was actually there was a good coordination of activities. So this is just a quote from one of our interviews with experts. And actually early on in Irish hospitals, there was great separation between COVID and non-COVID quite quickly. And that was one of the things that was really done well early on. So some of the challenges. So early on, there was initial slow expansion of the limited testing capacity. So that was kind of slow to get going. Early on also, there was a failure to block travel from heavily infected regions, such as Italy. That could have been done much quicker. And there was a late cancellation of public events, such as St. Patrick's Day in March 2020. And also early on, there was kind of ambiguity on whether to wear face masks or not. So we could have kind of made a more definitive decision earlier on. Another issue then, so a big issue kind of leading up to Christmas 2020 is when the politicians began to, slightly go against the advice of NPHET and the scientists, that they opened up quite quickly. And of course then they opened up and then they did lessen the restrictions a little bit, but it was kind of too late. And for a brief period in January 2021, Ireland actually had the highest infection rate in the world per capita. And then if we look at governance, so another big issue was the failure to support nursing homes early on. So this is a chart from a HICWA report. So we see in the blue line is 2020, and then the rest is from 2016 to 2019. And we see the massive spike in the number of unexpected deaths in nursing home. So this is one of the most vulnerable populations, and obviously they were one of the most likely to have negative impacts from COVID-19 exposure. So unfortunately, they weren't protected in the way they should be. So in future pandemics, that's something to learn from and focus on. If we have a future pandemic, hopefully not. And then, so from this chart, it's from a more public opinion tracker from 2022, one of the reports. So this looks at the general kind of what does the general public and their opinion of the government response to COVID-19. So we have in purple appropriate, at the bottom dark blue is too extreme, and then the light blue is insufficient. So we can see overall there's very high levels of approval from the general public in the government response. In general, compared to other countries, people thinking it was too extreme is quite low. And this chart also shows that at that time in October 2020, when politicians were, there was a decision to made in government that they would open up, most of the public didn't agree with this. So the majority of the population thought that they were opening up too quickly and actually were kind of agreeing with what the scientists' advice was. So overall, good approval for the government. And then other times when people weren't so sure, of course, was in January 2021, when we had really high infection rates, and also Christmas 2021 going into 2022, at the time with Omicron and some high infection rates. But overall, people were happy with the government response overall. So now if we go to the finance section, so 2 charts here. So in the first one, we see the annual change in real current government health expenditure per capita from 2009 to 2021. So as we can see, the recession period to recover to COVID. So there was beginning to be an increase in 2014 and then continued into the COVID time period. And then the bottom slide here we see, so this is from 2016 to 2020, and we have estimates for 2021. So this is a proportion of government spending, voluntary healthcare payments, and then household direct payments. So we can see that during COVID, there was a great increase in the percentage of government spending. So it was 72.7 in 2016, it went to 79 in 2020. And this puts us in line more with the EU averages. So the EU average is around 80%. And then as a proportion, then relatively, the other two sections have slightly gone down. It's a good increase in government spending as a proportion of total health funding. To move on to the next session for human resources. So this chart looks as acute staff versus community care staff. And we have it for the recession period from 2008, the recovery period, and then COVID-19. So as you can see, during austerity, they both went down. There was the beginning of the recovery from 2014, and we see the COVID period. And as we can see, unfortunately, there's this policy intent. We want more people in community care, and that's been a real policy focus of recent years. But unfortunately, as we can see, there's a growing gap. So as the recovery began, we see there's much greater recovery in acute and a much slower increase for community care. And even during COVID, this gap even widened further. And unfortunately, when we look to 2021, we still actually have lower levels of staff in community care compared to what we did have in 2008. And then so the next chart for human resources, so we look at turnover. So this is from the different staff categories in the HSE from 2018 to 2022. And unfortunately, we do see a worrying trend. So in the dark blue, the 2022, across the board in every category, we see that there's an increase. The highest is in health and social care professionals, then medical, and then nursing and patient and client care. And the lowest turnover in general is in general support. But as you can see, this is a worrying trend. And in Ireland, when we already have some staff shortages, we have a lot of vacancies that can't be filled, such as in consultant posts, etc. Also nurse vacancies. Already a lot of staff will emigrate for better pay and working conditions abroad, and we're quite reliant on foreign trained staff. So these are all issues we have, and unfortunately, it's not going in the right direction. So for service delivery, this chart here is hospital beds per 1,000 population. And unfortunately, you can see that we really didn't recover since austerity. So in 2005, it was 5.46 per 1,000 population. Then when it dropped, it's only been around 2.8 from 2009 to up to before COVID-19. So yeah, so in 2019, it was 2.9 hospital beds per 1,000 population, which is the third lowest in the EU. We only had 5 intensive care beds per 100,000 population, and the EU average is 12.9. Also, Ireland was one of only 4 of the 27 OECD countries with acute care bed capacity at a rate of above 85%. So we often had acute care capacity, much higher than what's considered safe. So that's what the situation was moving into COVID. But so from positive news, if we look at how we increased capacity during COVID-19 in critical care bed, it is actually a success story, because in a relatively short period of time, we were able to increase the critical care beds by 36%. And a really important part of this also was that we never were overwhelmed. Like in other countries, like such as Italy, they really were on the edge with the rising case numbers. But for us, it reached 95% occupancy in January 2021. But the system wasn't overwhelmed. And a part of the response was actually there was really good information system. So we had real-time data and information that was sent to decision makers, so they knew what was happening on the ground and what the capacity was at the time. So it was good to, they really benefited from the real-time data. And then the measure taken, obviously, were suspending non-urgent care. They designated more spaces to critical care. There is the redeployment of staff and the upskilling of this staff. And also they made use of transferring patients to private hospitals. And then also we look at the mobile intensive care ambulance service, that they actually were working 129% compared to what they normally do. That's compared to 2019. So here for service delivery also we look at waiting lists. So unfortunately they're quite high in Ireland. This chart I picked out from the report is the total inpatient and day waiting list. And this includes actually the adult and children list. So as you can see, this is from January 2016 up to July 2022. So in general, it is at high levels, but it peaked in mid-2017, and we see that there was progress. So it was generally going down and there was improvements made. And then we see the spike where COVID hits. So in spring and summer 2020, we went back to extremely high levels. So we went into the pandemic, obviously, with high waiting lists, and then we weren't in a good place, and then a massive increase in COVID. Then there was some recovery, then kind of back to Christmas again at the spike. And now kind of a little bit of a plateau, so they remain at very high levels. So for medicines and technology. So there was some good progress during COVID-19. So with the vaccination program, there was this mechanism that finally the individual health identifiers were created. They're a mechanism that how we can assign these identifiers to the larger public in Ireland. So that was really a good thing from the pandemic. And of course, there was the increased use of telemedicine. So just the chart here is the electronic general referrals by GPs from March 2020 to May 2022. So obviously just a general trend upward, which is really positive. But unfortunately, even though we have these individual health identifiers, they're still not in use. Like we have the mechanisms to assign it to people, but it's not up and running really because we don't have electronic health records. And if we look at the eHealth Ireland strategy, it was first published in 2013, but many of the objectives are nowhere near like being achieved so far. So if we look at the electronic health record, so in Ireland, there's no universal electronic health record system. There's just siloed IT solutions, and often it's in specific populations or systems, but there's no way to communicate between the systems. And then also, so as part of a recommendation, but also like looking at the e-health sector in Ireland, there's just not the resources put into it that there should be. We only spend about 0.8% of our total budget on e-health, and peer countries spend about 3%. So we really need extra investments because, as I said, so many things that were outlined in 2013, are still not achieved. It's a long way to go before it's the vision is fully realised. It'll be a long way yet. Okay, so to the recommendations. So I just have a few highlights from each. So if anyone's interested, obviously there's more information in the report. So for governance reform, we should invest in enhancing public trust by building on the successes of the response to the COVID-19 pandemic to co-produce a vision of the implementation and realisation of Sláintecare. For workforce and resourcing, as mentioned, with staff levels in community care, we need new models of care in primary and community care settings, and we need, proper career opportunities and progression that is, competitive with the acute sector, that there are clear pathways for, competitive alternatives that encourage people to go into community care. So then just some more recommendations for service delivery. So with the progress that was made during COVID-19, we should maintain the increased use of telemedicine, of course, where appropriate. We should establish more appropriate pathways to access care outside emergency departments, because of course we know in Ireland there can be a bottleneck at the emergency department, so we need to really establish appropriate pathways outside of that where people can get proper access. And then for waiting lists, we should prioritise reducing waiting lists and shortening waiting times through enhanced funding for buying care for long waits. And we really need improved information systems along with accountability if we're really going to tackle the waiting list problem. And then for medicine and technology, we should increase the health budget, as mentioned, to at least 3% because there's just not enough resources going in. And we need kind of the vision to have a universal system. Again, it's just kind of subpopulations, but we really should look to invest to have universal access and use the individual health identifier so, all people can have integrated care. And then, okay, so preparedness for future shocks. So we need to review governance protocols and scenario planning for future shocks. We need to, flexibility we found during COVID was really important. So we need to evaluate flexibility of workforce deployment and infrastructure for future shocks. We need to evaluate how day and night respite services and community care can be better protected in future pandemics. And then now with the cost of living crisis, we need to evaluate healthcare system readiness for renewed austerity. We need to look at kind of lessons learned from the austerity area, learn what happened back then, and so we can assess the likely areas of impact. We need to secure financial protection of healthcare services and health facilities from cost hikes. And of course, with the cost of living crisis, we should consider dropping access costs and implementing free healthcare. So thanks. So I'll be at the session if anyone has any questions. And of course, please, most people, you can have the executive summary, and the full report is available online as well. So thanks. So questions later on. I kind of flew through that. More time for it. So thanks.
Thanks, Padre, and thanks to everyone that came. Well, staff engagement is part of the component 3 of Restore project. So today we're going to be talking about the barriers to resilience among healthcare staff in Ireland in the post-austerity period, a cross-sectional analysis. The first thing that we did when we were trying to understand staff engagement was that a difficult task, that is conceptualize staff engagement. There are major differences in the definitions of the staff engagement, and one of the most commonly utilized explaining as a psychological state or attitude in which people are positive about traits such as satisfaction, commitment, and involvement toward their job, role, or organization. According to worldwide statistics, around the 35% of the population of the health staff are committed or compromised with their organization. However, it's very difficult to make any comparisons between countries because there is major difference in concepts, but not only in concepts, but also in theoretical frameworks. And of course, derived of that, there is major difference in the instruments that have been utilized for measuring staff engagement. Also, most of the theoretical frameworks have an organizational approach, but they have some weakness related with the individual characteristics or the influence or the impact that the employee's characteristics could have on the overall staff engagement. These are some of many theoretical frameworks that have been done for evaluating staff engagement. And as a COVID-19, there is a need not only of general interventions, but also personalized intervention on staff engagement that target specific populations for guaranteeing not only the engagement of the health staff, but also to guarantee the retention of the health staff in the Irish healthcare system. So Ireland, and specifically the government of Ireland and the HIC, have been interested on staff engagement, and actually staff engagement is part of the framework for improving quality in our health service. Because of this, since 2014, the HIC have been conducting surveys on staff engagement that are called Your Opinion Counts. These surveys were assessed utilizing the Ipsos model. If we look at the survey's outcome, as you can realize, most of the outcomes were satisfactory. And in most of the dimensions of the Ipsos model, over 50% of the health staff were satisfied with each of these dimensions. So, good. However, if we look at the model that was utilized for evaluating staff engagement, we realize certain things. First, it's a Canadian model. Second, was mainly utilized for evaluating engagement on private business. So it's not an Irish model, and it's not an Irish model specifically for the Irish healthcare system. Also, the Ipsos model have the same problems that its predecessors. Like, for example, it have mainly an organizational approach and doesn't have into account the individual characteristics of the employees. And last but not least, Your Opinion Counts was an amazing work and comprised around 151 questions, and only 12 of them were utilized for measuring the staff engagement in the country. So, what should we go from this? Are we measuring what we should be measuring? So that's why our main goal for our thesis, and also as part of the Restore project, is to assess the general trends of staff engagement, and not only the general trends, but also what are the dimensions that are comprised in staff engagement, and what are the variables in each of these dimensions that are important to measure, to have an understanding for evaluating staff engagement. So in order for doing this, we're going first to develop an engagement measurement framework, an instrument but specifically tailored for the Irish healthcare system. And we're going to identify what's staff engagement, what are the dimensions of staff engagement, what are the variables associated with staff engagement, and we're going to validate each of them utilizing the rich information that we have in the HIC collected data on staff engagement. And last, we're going to compare and analyze the outcomes that we will obtain with these new theoretical frameworks and the outcomes that were obtained with the Ipsos model. So as part of this, our methodological approach is mainly a mixed methods approach. We have first a quantitative phase for the construction and validation of this theoretical framework, and this phase has a first step related with the conceptualization that we did mainly through a scoping review, and at the same time, in an iterative process, we extracted suitable data or feasible data that we already have in the HIC data sets on staff engagement. Why we're doing this? Because after we have this, we're going to be able to develop the measures of staff engagement and operationalize the construct of staff engagement. And after doing this, we need to validate is this actually what it said it means? So for validating, we're validating each of the variable, each of the dimensions, and for doing that, we're utilizing mainly empirical and reflective construct validation, structural equation modeling, and factor analysis. After this, we're going to be explaining our results in the quantitative phase. So we have a second qualitative phase where we'll be utilizing focus group for explaining our findings, and finally, we'll have an integration phase with utilizing pillar integration process for explaining all of these outcomes. Today, we're going to be mainly talking about the conceptualization and the development of the measures. So as part of the scoping review after our search strategy, we obtained around 1,800 articles. And after the title abstract and the full test screening, we only incorporated around 155 articles. The geographical distribution of these articles, or if we want to say it in other words, where most research have been done related on staff engagement, is in the United States, as you can see there, in China, and it's not very evident here, but also in the Netherlands and in the lowest percentage in the United Kingdom. The Netherlands, probably some of you know, the very famous Utrecht scale on staff engagement has been utilized in many occasions. So that's why the Netherlands have huge research on staff engagement. And the period of time where most of these articles were developed was 2000 and 2010, because the Utrecht scale was developed during that period of years, and most of the research was done during that period of time. So after reviewing the results related with the staff engagement, we have mainly three approaches. The first one is the multifaceted approach, or the multidimensional construct, that says that mainly staff engagement cannot be explained utilizing just one variable. We need two or more variables for explaining what's, this difficult phenomenon of employee engagement. Then we have the organizational approach that mainly talks about the willingness that the employees have for staying in their organization. And then the individual approach that is completely the opposite to the organizational approach, and mainly explain a positive state of mind, how the employee feels with being part of that organization. The individual and the organizational approach are separated, but they don't recognize the influence that one has on the other. So the multifaceted or multidimensional approach is a more complete approach. Based on this, there were frameworks developed based on this concept, and also measurements developed based on these frameworks and this concept. But in general, what are the most important dimensions associated with the staff engagement? The organizational dimension, very important, but also the individual dimension. The organizational dimension, probably most of us knows that, is mainly related with communication in the organization, related also with management style, with work role fit, and these kind of things. But then we have the individual dimension. We have psychological state variables that need to be have into account, like self-esteem and also positive coping styles of the employees. We have demographic variables like sex, also years of experience, and we have work-related variable. But this work-related variable from the individual perspective, not from the organizational perspective. So these work-related variables are mainly related with the staff category and the areas of health service where the employees work in. So this is the second part of the project. This was the extraction of suitable data from the HIC datasets. And we mainly utilized the 2016 and 2018 datasets because they were methodologically similar. So it was possible to merge the datasets. And we mainly did a repeated cross-sectional analysis utilizing descriptive statistics as baseline characteristics and also ordinal logistic regression for explaining what's the impact or the importance that these variables could have on the staff engagement. And also, we also create or generate some post-stratification on non-response weights because the response rate of the surveys was very low, was around 15%, was mainly for decreasing the response, the bias associated with the level of representativeness of the sample. What were these results? So this is the organizational dimension. As you can see here, all of these variables like teamwork, optimism about their work, motivation, stress, all of these were associated or correlated with the staff engagement. However, we went further and we want to explain what was the satisfaction of the employees with each of these variables. And as you can see here, the variables where the employees were more dissatisfied were the communication in their organization, the training and career progression, and they weren't confident of the strategy that their organization followed. But we don't stop there, and we went for the individual dimension. So what is important to have into account from the individual or from the employee perspective? First, sex, to be a female, was correlated with disengagement. It's more probable to be disengaged if you are a woman than if you are a man. Also, bullying and discrimination were highly correlated with disengagement. Some staff categories like medical and dental, nursing and general support staff, national ambulance service, some healthcare services like primary care, mental health, working in the Irish system for more than 5 years, and some community health organizations. But how does it translate? I mean, why this is important? Catherine, my colleague, and me have done some research on this, and we did some subgroup analysis based on that. We analyzed the different categories or staff categories to look for disengagement, having into account the staff categories. And for example, it was interesting that a disengaged nurse is more likely to be working in the ambulance national service than in acute hospitals. A disengaged nurse is more likely to be working in primary care than older people services. And in the case of the nurses, the contact with patient was correlated with disengagement too. If we look at the doctor, there are some similarities, like for example, it's also more likely to be to work in the ambulance service, a disengaged doctor than in acute hospital, but instead of primary care, it's more likely that a disengaged doctor is working in health and well-being in comparison with older people services. And in the case of the doctor, the contact with patients was not an important variable for the disengagement, but the years of service. So if you have been working for more than 5 years in the Irish health service, it's more likely to be disengaged than if you are not. And last but not least, bullying and discrimination were highly correlated with disengagement. So what are the key messages of this? First, the general message, and is that we need to have into account not only the organizational perspective, not only organizational variables for evaluating or for measuring staff engagement, but we also need to have into account the individualities, the individual characteristics and the importance that they have for like creating or developing any theoretical framework or any instrument for evaluating staff engagement. Two key messages from the organizational perspectives were first, the communication strategies are without doubt the best approach for guaranteeing the retention of the health staff in the Irish healthcare system. And second, the enhancing of the opportunities of training and career progression are also very important. And as part of the individual dimension was our key message, bullying and discrimination. Bullying and discrimination were highly correlated with the disengagement of the health staff. So health organizations should offer more information on the available service for coping with discrimination and bullying to their staff. Thank you so much. I'm looking forward to your questions, and thank you for being here.
Ewout, would you like to give us your views on thinking about legacy issues associated with COVID-19? And obviously you touched on some of those, but what were the key legacies for you as we move forward into this kind of perma-crisis? Are there any positives that we can take from COVID-19? And how can we get better perhaps at dealing with those legacy issues at an EU level?
Ooh.
An easy one to start.
Yeah, I know. I thought you were going to give me an easy question, but of course I mentioned some. Now, I was impressed, I think, during COVID, how much is possible when everybody is facing such a challenge. So I was impressed also, our role, how quickly we could set things up. I was impressed often how quickly also, the policymakers and, were apparently all of a sudden could change things that couldn't be changed for years before. So I think, that should teach us that we, going forward, that things are possible. And, I hope that we can retain some of that. If that is a legacy of COVID, then I'm happy.
Great. Anybody else want? Yep. Louise?
Hi, I'm Louise Caffrey from Trinity. First of all, thank you so much for this presentation. There was just so much information in it that's incredibly valuable. I was thinking about something that seemed to reach across the presentations. You mentioned that, you know, the importance of evidence in decision making, and then obviously the kind of macro level that we are producing evidence for decision making. And Catherine mentioned the issue of delayed decisions on mandatory mask use in Ireland. And, you know, we could see that across countries, I guess, and the diversity of policies there. And I was just thinking about the issue of how we think about evidence in a crisis and use it to make, you know, decisions that are made at an appropriate time. And some of the issues in that around how we value evidence, what constitutes valid evidence. So within the face mask example, you know, the problem of thinking about the medical model of randomized control trials as the gold standard for making that decisions in some contexts. And I wonder if you could just comment on if there's anything we can learn from the evidence so far around how we use evidence to make decisions in a crisis and what constitutes valid evidence or should constitute valid evidence in that. Thanks.
I think one of you want to start first.
Me? Yeah, I think, you know, a wonderful thing that happened during COVID was all the massive information that was coming in. So everything was monitored, the number of vaccinations when that came in, before that the numbers of infected. So we do have an ability that we could have so much data, and COVID could kind of teach us that when we really needed to, we could create these data systems, and just moving forward, we need to just increase that. And I think that's where we want to go. There's obviously issues around privacy and all that with people, but for making, and when making decisions, you know, especially in a pandemic, it's hard to know, you know, they weren't, you know, for face mask use, maybe it wasn't effective, you know, something like that, maybe they just didn't have that information at the time. So yeah, I mean, and in general in all this, we just need more information systems and more data and try and build that across the health system.
Yeah, and actually, just to jump in there before yourself about, I think it's really interesting with how the public responded to this huge amount of information and really kind of got behind it and almost started demanding better information and quicker information. And for me, I think that just speaks to how valuable data is and how we really need to be investing in better data and making it more accessible to the general public. But yeah, sorry. Ewout, did you want to reflect on that question?
Yeah, it's an interesting one because, for example, using your example of the masks, I think the Netherlands was the last one to implement masks. And although I'm not an expert in this, I do think now that we're still not 100% clear in how far they work, but you know, some seem to be very convinced. We need to also understand that, you know, when we disseminate evidence, are those snapshots that I was talking about earlier real, you know, validated evidence? I'm not sure. We were providing options because we as researchers need to understand, we need to give them options because they will have to make decisions. So therefore I also said, evidence-informed, information-informed decision-making, not based, because you know, in a crisis that's happening, you cannot. But we, as a research community, because we're so strict and thorough, we often shy away from then, you know, giving advice. But you can caveat it and say, listen, this is what probably on the basis of what we know you could do. And in terms of the masks, I never understood the whole debate because I always felt, you know, what kind of sacrifice is that? You know, and if it doesn't hurt, it doesn't hurt. So, and if it works in the end, great, you know. So, very difficult question, but I do also think that we need to, you know, think really critically about how we communicate also preliminary findings and at what stage. And, you know, is it evidence what I was talking about or just information, options? You know, at some point it turns into evidence perhaps when it's more validated and you know, but went through all the methodologies, but yeah.
And coming back to Catherine's point, I think that you also was talking about the importance of primary care in these cases and the sharing of data from primary care for in order to have a, you know, like more information about what to do, what's the next steps. So I think that's a problem still in Ireland that we are trying to solve, but kind of sharing the data across all the health systems is a huge thing in this case.
Great. Sarah, yeah, thank you.
Thanks, Sarah.
Sarah, we might just wait for the mic. Liz is coming.
Thanks very much. Thanks for all the fantastic presentations. It was interesting out you talked about governance and leadership being the biggest issue, and Ariana highlighted, I think it was you or maybe it was Catherine, I can't remember, but you spoke about communications being the biggest issue. And I suppose I'm just wondering, when we're thinking about evidence, what about when evidence doesn't matter or is not valued? And just to flip the question a little bit, what is if we are researchers, what is our role in that outcome? You know, what can we do differently?
So do I understand correctly also that how can we make them use our evidence if they're ignoring it first? Is that what you mean?
Well, just usually I'm working off the principle, if fake news is going to be a big problem, and that's part of governance, leadership and communications, usually if you want to change something, you start looking at yourself. So I'm just wondering, as researchers, if that's how we identify as researchers, for the researchers in the room, what do we need to be doing differently?
I think that we in general need to become much better at communicating our evidence, and also, much more, not shy away, and hide behind our papers, really get out there and also be part of the debate. Something that we've been trying to do in the observatory, we try to help shape and put maybe pressure, as you maybe could say, do webinars all of a sudden. We weren't doing these 2 years ago on a range of topics. Try to organize things with policymakers, be there. Yeah, really, I think my work in the last 2 years has changed much more from a producer of just information and reports to somebody who was sitting in meetings like this and then also trying to talk about it and convince. And I think that we probably need to educate, our students also in these kinds of skills. How do we communicate these so that hopefully they will be used in the future by our policymakers. So that's where I think our role should be.
Yeah. Sorry, Ariana. I was just going to jump in and think back to your slide of all the various different political leaders at the time, and of course, we know that at least 2 of those are instigators of fake news, and it's this challenge, like how robust do we need to be in challenging some of the political leaders that are driving fake news, and how do we balance that between the kind of public dialogue and the actual evidence? It's a tricky one, and a lot more thought needs to be given to it. Sorry, Ariana, I interrupted you.
I was just thinking that, in my research, one of the problems was related with the communication with supervisors and managers in the case of the staff. So sometimes if the awkward communication and how that's transmitted, how clear is transmitted, how is explained to the health staff for, having an idea of what is happening. And also I think as researchers, we should not only focus in, as it was said, articles or our research, but also having to account what is happening in the front line, what are the real problems, and, introduce that in our research, because it's a way of also incorporating those frontline workers to our work and have their perspective on it.
And actually reminds me of, again, the Realist Review. One of the findings that we found in that review was a disconnect between the values of healthcare management and the values of those delivering staff. So during the austerity period, there was this perceived shift towards keen interest on economic values and efficiencies and things like that. And frontline staff actually felt, where are the patient-focused values that we've been working towards our whole lives? Like, where are the quality values? Where are all these various different professional values? Where do they lie in this? And it wasn't that neither were important, but there was just a lack of communication between management and frontline or from political leaders. And I think that really needs more attention if we want to try and tackle the fake news and the kind of counter arguments that are out there. I'll stop talking and see if anybody else wants to ask any more questions. Yep. Greg, yep. Liz is coming.
Thanks, Greg Dempsey in DOH. Thanks for the presentations, really interesting. Ewout, you mentioned e-health and said you had some caveats. I'm kind of interested in what those caveats would be.
Yeah, So I think evidence is still inconclusive. It probably works well for certain services, but not for everything. And the other one would be, to be a little bit cautious that it doesn't, there may be certain groups, vulnerable groups, who will have more difficulty benefiting from some of these solutions. So I think there needs to be extra attention for that, or you may even increase, inequalities in healthcare provision. On the whole, I think it's a good thing, and Ireland is looking good, at least from the slide I have. I don't know, maybe more insight.
I disagree.
Okay, she disagrees. Then it was just about use of
GP telemedicine?
yeah, exactly.
Yeah. So, that
so
was
that's
a good
just
part.
one small part. But I think that, this is the thing that from the Department of Health do not want to hear. More research is necessary. But I think that we need to be a little bit cautious here, because I felt that also internationally that all of a sudden this was solved as the big solution, whereas I think the solutions are much more into the workforce, the new care model, keeping people out of hospital, integrated care in the community, that stuff.
Yep, Sarah. Liz, back to the front.
I disagree every piece of research with the people who are delivering integrated care at the front line, data and access to digital information that can inform what they're trying to do with care pathways, referrals, patient handover, all this. Everything is saying they're putting e-health at the very, very top of that list of challenges.
I agree. Information systems, no doubt about it. We need those. Don't want to discuss that. I was more thinking about some of the other solutions in terms of, online consultations, that kind of stuff. So I was not thinking about information system, because I think there, you're right. There's a big promise. We need that kind of information system.
So I think what we hear when you say that is the lack of our system. That's
right. Okay. That's possible.
My perspective around in that very specific one. I agree.
Yeah.
Okay.
Catherine, did you want to add anything to that, or?
Ireland did do well with kind of virtual clinics compared to other countries. That was actually quite done well. GP, calling up the GP and actually using things like Zoom actually was done quite well. But it goes down to information systems that could be way better. Yeah. And it was a plan for universal electronic records, but the government actually kind of then just decided they would only do it for the new children's hospital and that kind of thing. So there's kind of a lack of commitment to actually having universal electronic records. So moving forward, that's going to be a big issue.
I think many other countries as well, unfortunately.
Yes, Liz. Sorry, we just have the one mic. Liz having to run around. Just over here. Thank you.
My name is Margaret O'Riordan. I'm a GP, former president of the Irish College of GPs. So I'm just interested there in the electronic health discussion. And I think what I see there is maybe an issue once again about communication. So while I agree with Sarah, we all want access to guidelines, we want electronic access. When it comes to the actual patient perspective, and speaking as somebody who was on the front line in COVID, who had to adapt my practice and who had to move to virtual consultations, we did find, I'm a rural GP, would have a good few of older patients, that certainly teleconsultations by telephone worked effectively, very effectively, for the vast majority of patients. But your electronic, your telecommunication using a Zoom or whatever would have been for lots of practical reasons, like didn't know how to use the technology, number one, access to broadband, number two, economic perspective, number three, didn't work as well for us. So I think really what it comes down to is the electronic piece about information for health professionals. Yes, excellent. The more we have, the better. But in terms of patients and a focus on patients, teleconsultations work very well for the simple problem. Versus during COVID, 90% of the consultations were, I have flu-like symptoms. Is it COVID? Is it a cold? Can I have a test? versus the reality of dealing with someone with a mental health issue, for example, where teleconsultations really are very difficult. And so I think the caveats, to come back to your question, really focus in on vulnerable patients, be they elderly, be they economically disadvantaged, number one, that cohort, and number two, what is the subject of the consultation that you're trying to deal with. So I think, you know, you have to bring it back down, as you were saying, Corey, to the practical implications. Our health service should be patient-focused, number one. Our research should be patient-focused, and it is. But it's sometimes we get lost in the bigger picture, and sometimes it's no harm to bring it back to the focus. And I think that they are, as a healthcare provider, they are the caveats I would have. I welcome it. It was wonderful. We transformed it literally within a week from all face-to-face consultations. I virtually never did telephone consultations, very, very rarely, to 90% telephone consultations. So it shows what can be done. It shows the flexibility. It shows the willingness of healthcare workers to adapt. So I think there's a lot of richness there. But they are my caveats. I don't know if that's what you meant by your caveats.
Yes, thanks for clarifying for a large degree what I tried to say, and it confused you because, what I would call a digital system or information system, or an EPD and patient dossier. But this is exactly what we're talking about. And what I also often hear is, also these are probably patients you perhaps know, and then it's maybe easy to do follow-ups. But that first consultation, to see a person, in person, I think often is a key one. But if it's just a population you know, and that's probably the case, you can probably do lots. I'm just, I think, these caveats we need to work on and need to clarify and not sell it as a solution for all the problems, because it obviously isn't. But it's a very helpful tool. I like to talk to my GP per email. Like often you already know what's going on or what you need or whatever, and they can help you very easily. And then I don't have to go there and lose time. It will be quicker for the GP as well. So.
And I think this speaks to the point that we're making around the need to invest more in the learning and legacy stage of the shock cycle. So when we did the systematic review, there was a lot of literature on the other stages, but very little on the learning and legacies. And this is a prime example of where we need to do more work on trying to understand the nuances of eHealth. And it's actually one of the recommendations in the press report as well, is to let's spend time figuring out what worked well and build on that, and things that we just did because we had to, but didn't actually work that well, maybe we need to drop them. But that work needs to happen, that conversation needs to happen. We're actually out of time now for questions, but there is coffee after arriving. I'm sure everyone's delighted to hear that. And I just want to take the opportunity to thank all of the speakers in the first session, and also all of the collaborators on the various different Restore projects. So thank you very much for your attention, and thanks for speaking.